morning, everybody. Let us begin this workshop on MIS technologies, especially the tubular discectomy and tubular system. In the morning, with the first session on basic concepts. I'm sure all of you are quite aware about the anatomy of the lumbar spine with all its nitty-gritties and the nerve roots and the dural tube and the various bony landmarks as well. The most important concept is is regarding the exiting nerve root or the traversing nerve root. So if we take a look at the L4-5 disc, the nerve root that traverses through and exits at the level below the L4-5 disc space would be the exit traversing nerve root, which would be the L5 in this case. Whereas the one that exits at the same level, that is the L4 nerve root, would be the exiting nerve root. As the L5 goes below, it becomes from the traversing root, it becomes the exiting root at the L5 as well level. If we take a look at the various areas where stenosis is quite commonly seen, the central area of the thecal sac comprises central canal stenosis. Anything that is lateral to that becomes the far lateral or the lateral canal stenosis. The area between the two pedicles encompassing the foramen becomes the foraminal stenosis, and further lateral beyond the foramen is the extraforaminal stenosis. A disc herniation may present as a central variety, a posterolateral variety, foraminal variety, or a far lateral variety as well. So if we take an example of the L4-5 disc herniation, a standard paracentral or a posterolateral herniation is likely to catch the traversing nerve root, which is the L5 in this case. Whereas if it is an extraforaminal or a far lateral disc, then that same L4-5 disc would catch the exiting nerve root, that is the L4 nerve root. These concepts are quite basic and need to be understood very well so that you can target the appropriate nerve while recommending any treatment to your patient. Cambin in 1987, almost a decade before Foley invented and developed the MEDs, showed that an arthroscope can do the work of and you can do a minimal invasive discectomy using an arthroscope. Foley, after developing the MED system in 97, developed the percutaneous screw system, and then eventually developed the metric system wherein you can use a microscope as well. Subsequently, MIS lifts were also developed along the same lines. So if we can take a quick look at Kevin Foley, he and along with Morris Smith developed the classic posterolateral approach and the metrics tube, which subsequently had a very significant amount of applications across the lumbar spine. Anthony Young developed the transforaminal approach, which was basically a modification of the Cambin's approach, and he has popularized this quite well using the 7 mm cannula. And then John Destando developed the endospine surgical set, which is quite popular among the neurosurgical community. Subsequent to that, Sebastian Rutten and Martin Comp developed the full endoscopic technique for the interlaminar surgery for lumbar disc herniations, as well as the transforaminal as well. And they have published a lot on these two techniques, and which has now almost become a full technique to reckon with. So if we take a look at the various options, the central midline approach is being used for the open hemilaminotomy cases. Destando uses it, and for the interlaminar endoscopy surgeries also tend to use the midline or the paraspinal approach. The classic posterolateral approach is being used by the tubular discectomy systems, and the transforaminal systems is being used by the Young systems as well as for the full endoscopy systems through the foraminal route as well. The target for all these interlaminar and the interlaminar and the tubular discectomy systems are the interlaminar area, Whereas for the transforaminal option, the target area is basically a Cambridge triangle, which is a triangle bounded by the exceeding nerve root, the superior edge of the transverse process, as well as the traversing nerve root medially. The superior articular process lies in the floor of this Cambridge triangle. Now, if you compare the four options of tubular variety, the Destando, along with the transforaminal and full endoscopy, then all these systems have a learning curve, which may range from 20 to 40 cases. The transforaminal has a slightly steeper curve, but is easier to master as compared to the full endoscopy technique. The application of all four of these systems is possible in the cervical system. However, the transforaminal in the full endoscopy does
Huh?
require a narrow
Yeah,
gauge.
our internet is not
Look at
working.
the versatility of these systems.
No,
The
as in
transforaminal system,
working, connecting to it, but there's no internet there.
except the
Something
transforaminal system, all the three are able to undertake an L5S1 surgery quite effectively. You can also do single level, multi level decompressions. You can do over the top decompressions with these systems, and you can also remove tumors as well. So, in effect, except the transforaminal system, there are no limitations with the other three systems.
oh,
The tubular variety as well as the transforaminal variety can be used in conjunction with percutaneous pedicle screw systems to effect a bony fusion and undertake a minimal invasive surgery for a fusion as well. And both these techniques are also quite user friendly and have become quite popular. That leads us to the one fundamental question that keeps dogging the Indian mind: the cost. What is the cost factor? And except the tubular variety, all the other three systems are quite expensive and require a lot of investment in your setup. Now, if we take a look at the matrix tubular system, it comes with an array of tubular dilators which are sequentially increasing in diameter. And then there is the tubular retractor, which has actually changed from what you're seeing here. It has now changed quite a bit in design. And the articulated arm for holding the tubular retractor has also now been replaced by a series of three rods. I still do have the original system, which is why I put up this picture. The light source can be used as with a fiber optic system, which was the original for the MED system. However, it can still be used along with the headlights and loops if you wish to prefer surgery with this setup. However, the best would be using a microscope with a significant amount of magnification and excellent light to give a very good picture. Looking at the indications of this surgery, the classic posterolateral disc prolapse is the main indication. You can also do it for the migrated lumbar disc or an extruded lumbar disc. Foraminal discs can be tackled. Synovial cyst without instability can be managed very well with just the system. Unilateral or bilateral lumbar canal stenosis can also be tackled very well. The posterolateral cervical disc herniation can be managed along with the drilling of the osteophytes through this same technique. This can be used in conjunction with MIS fusions for the MIS TLIFs as well. A large central disc prolapse such as this is a significant contraindication, especially in your early cases. And if there is such a large disc causing coda equina syndrome, best tackle it in an open technique, just as you would probably do this multi-level disc prolapse case. Bilateral severe lumbar canal stenosis with a constitutionally narrow canal is also best tackled open rather than in a MIS form. The significant advantages of this system, the first being the tiny incision. It's just as small, less than an inch, the incision, as compared to the large incision that would otherwise be there on the back of this lovely lady. It has a significant amount of cosmetic appeal, and there is also a significant amount of reduced muscle dissection. The visualization is fantastic. There is significantly low blood loss, and the pain is far, far, far more tolerable. The patients are able to walk early. In actuality, they are able to walk within the first 3 to 4 hours only, and they are able to go home early. They can return to work in an early manner, and the recurrence, if it has happened, can also be tackled in a similar fashion. There's a significant learning curve associated with all these techniques, as we have seen earlier. They all require specialized equipment as well, and there is an increased cost. But this is offset by the reduced hospital stay. This paper by Marcotelli did quote that there is a slightly increased risk of dural tear and root injuries as well as recurrent disc with the MIS tubular system, which, however, has been found to be statistically not significant and has been unsubstantiated by other authors. A quick look at the approach. It is mainly paraspinal and an intramuscular approach. The laterality of the incision varies depending upon the procedure. Whether you do an MIS discectomy or decompression, it is going to be about 1.5 to 2 centimeters lateral as compared to an MIS TLIF, which requires a lateral incision of about 3.5 to 4 centimeters depending upon the width of the patient. You tend to make skin markings like this, especially in the fusion cases, and then subsequent to that, you need to do a perfect targeting. My colleague will deal with this in a much greater detail, and so I'll not delve into it a lot, but I'll quickly show you the point where you need to dock. For the microdiscectomy, it is the inferior aspect of the lamina of the superior vertebrae where you need to dock your first dilator and subsequently proceed from there. Whereas for the MIS TLIF, it is the superior articular process of the vertebrae below, which is going to be your docking point. Once you have inserted your first vertebral dilator, subsequent dilatation leads to development of a corridor through which you can eventually look inside and eventually visualize the classic three areas which define your location. The topmost being the inferior edge of the upper lamina. Then on your side laterally you have the medial edge of the superior articular process of the lower vertebrae, and lower down you have this upper edge or the superior edge of the inferior lamina. This is the classic interlaminar exposure which you should be able to visualize. The tubular system has actually become a quite a blessing for the obese patient, because in order to visualize an inch at the bottom, you need to expose almost 6 inches at the top. Whereas with the tubular system, all you require is an inch at the top as well as at the bottom, and the skin incision is very tiny. The last slide, a few tips on avoiding complications. The first being that the guide wire should not be used. You must avoid plunging with the dilators. You must use a meticulous technique. Butylated instruments allow visualization of the area within the tube. Using fibrin sealants, use fibrin sealants if at all a durotomy occurs and you are concerned, and do not hesitate to convert to open if at all there is a spaghetti being visualized. Thank you very much, and the session is now open for questions.